So welcome back to our laparoscopic colorectal and then specifically rectal cancer surgery. We have Tom Cecil and Mark Coleman and Bill and myself, and we're going to focus in this section on training, how these guys trained, how they train, and how the National Lapco program was set up and developed. So I think we'll start perhaps with how both of you trained. Tom, when were you appointed, and how did you train in laparoscopic surgery?
I was appointed in Basingstoke in 2002 as a consultant, and I was really quite lucky in my training in that I was interested in laparoscopic surgery, and I'd worked in Basingstoke, and Bill was spending quite a lot of time in Strasbourg with Jean Leroy, and he kindly organised for me to go and spend some time in the unit there. And so I went out and did a short fellowship with them. It was old-fashioned training where you get to stand in theatre a lot and hold the camera for a long time, but I saw fantastic surgery, and it was a fantastic environment for thinking and learning, but not hands-on training. But I saw a lot of laparoscopic surgery, and I came back to the UK and I was working in Southampton, and I was really lucky that I got a day every fortnight where I managed to go down to Yeovil and work with Robin Kennedy. And Robin did give me in 2001 hands-on training at that stage. Robin was a great trainer, and he would let me always do a bit of the case. That was the first time I started to do some laparoscopic colorectal surgery. My final year was spent in Winchester with Bob Lane, and Bob quite liked the idea of being a laparoscopic surgeon, so he'd let me start some cases and do some cases laparoscopically. Then he'd come in after a while and say, right, time to convert, let's do this operation properly. But I got to put the ports in and do some bits. And so I came to Basingstoke with an idea that I could probably do this. There was quite a lot of debate about whether I should be doing laparoscopic gallbladders, and I was really keen not to become one of those laparoscopic colorectal surgeons who did gallbladders. I really wanted to do colorectal laparoscopically. And with Bill and Brendan's support, I picked a few cases and started doing some laparoscopic operations, and slowly evolved the program. As mentioned previously, it was a difficult time where we weren't supposed to be doing it for cancers, and we had this thing that Brendan developed called the Cecil polyp. You know, it was an early right colon cancer which we might allow to have a laparoscopic operation and call it a sort of polyp, so it wasn't a cancer, and we could do some cases. I was really well supported. Brendan would always pop his head through the theatre door when we were doing a laparoscopic case. I was given Friday afternoons, which was a great time. It was about 7 o'clock on his way home. Brendan would come in and say, oh, looks really good, and walk out again, leave us another 4 hours while we tried to finish. But we gradually evolved a laparoscopic program. We were able to appoint a fellow and gradually did more cases laparoscopically.
What about you, Mark? How did you get going?
Similar. I was lucky to do an upper GI fellowship in Brisbane in '99, and I did over 500 cases, mostly laparoscopic, but mostly gallbladders, hernias, splenectomies, fundoplications. We did the first liver resection in Australia with Nick O'Rourke. I was working with Les Nathanson, who's one of the finest technical laparoscopic surgeons I've ever met. Bit of bariatrics. Came back into registrar training. Similar to Tom, I used to go to Yeovil and watch Robin Kennedy. Became a consultant around the same time and started slowly to build up my experience. And through to the sort of mid-2000s, when I suddenly found myself as one of the only, and certainly the person doing most laparoscopic colorectal in the southwest of England. So people were sort of starting to pay attention and come and work with me. I got into the training process nationally by being part of the Association of Coloproctology Fellowship Program, where we started to have a new fellow every 6 months to train them. And then everything changed in the mid-2000s.
Do you think that anybody can be trained in laparoscopic colorectal, or are there people who just shouldn't do it?
Simply with laparoscopic surgery, a small number of people can't see that sort of 3D vision from a 2D screen, and you could argue maybe they can get around it with 3D, fine. The other thing I think some people really struggle with is using a non-dominant hand to retract, and I think it's useful in laparoscopic colorectal to have a versatile non-dominant hand in some cases to actually do parts of the procedure. But I think that is important, and some people just don't have that capability. And in our experience of training, a small number simply didn't have the skills.
And is it something to do with spatial awareness or?
Hand-eye coordination in that particular environment, visuospatial awareness, use of the non-dominant hand, and a respect for the tissues, and knowing that you just can't deal with blood loss with laparoscopic surgery, because then your vision suddenly disappears.
And how much training can we do on outside of the operating theatre? Is that developed much?
Going back along, you couldn't really do anything, and we started using cadavers, and we tested the versatility of cadavers, and of course the anatomy is perfect, but you don't get the bleeding. And they're expensive, and they're difficult to store and difficult to use, and they smell. And then with animal labs, the utility there is that you have anaesthetized animals controlled and regulated, but you can't do it easily in the United Kingdom, so you have to go to Europe. And the problem is the anatomy is different, though you do have the advantage of causing and having to correct problems with things like bleeding.
And you don't have pathology, of course, as well.
You don't have the pathology.
For instance, like a rectal cancer in particular, you can never have a rectal cancer in an animal.
What's advancing quite fast is the world of virtual reality and being able to simulate things real time from a virtual environment, and there's no doubt in future that people will be able to learn to a great extent the skills they need for laparoscopic colorectal surgery and other complex specialties in that VR environment before they transfer to humans.
So how have you then taken on this in the context of LAPCO? Tell us a little bit about LAPCO, and I know both of you were involved in LAPCO. Tell us how LAPCO evolved and what was LAPCO, just for some people may not know what LAPCO was.
So in the mid-2000s, we realized several things. There's enough evidence to suggest that laparoscopic colorectal surgery had a place. We also knew from meta-analyses that the self-taught learning curve was 150 cases or thereabouts. And during that time, the operating time was unacceptably long, the rate of conversion to open was high, and the post-operative morbidity hospital stay was unacceptably high compared to open patients. So we had the sort of conjunction of those two pieces of information and the NICE guidance, which led the Department of Health, Mike Richards at the time, to say, with a bit of prompting from our community, if you like, that we need a properly constructed program. And the government agreed to fund a one-year pilot program to sort of test the concept of, can we train existing colorectal consultants? We've got to remember as well that we in the UK benefit from having subspecialism, so not every Tom, Dick and Harry general surgeon can do colorectal cancer, and that came along with the Kelman reforms in the 90s. We have peer review MDTs, so it's a heavily governed and regulated process in which we kind of knew who needed to be trained. So we after a bit of early rejigging of the program, and I was lucky enough to take on its leadership and call it the LAPCO National Training Program, decided we needed to do hands-on training, so consultants training consultants in the operating room. We needed to apply as many metrics as we could to test the impact of this training program by doing formative and summative assessment and monitoring clinical outcomes. And that's where it all started. So it really got going, I suppose, 2008, 2009. And because we used a website to collect the educational assessment data, suddenly there was traction in the program and things started to happen.
And Tom, we were very, very fortunate that you led a program in Basingstoke, which was
so we were one of the 13 training centres, and we did this in conjunction with Frimley Park, Mark Gudgeon. We were a joint centre. There were lots of different models of training going on at the time. So some people believed that the way to deliver this training was that you should go to the surgeon's hospital, outreach, or in reach the surgeon would come to your hospital. We were doing quite successful clinical immersion courses where people would come for a whole week and not only operate in our hospital, but they would watch other people learning. So you'd have a whole week where you've been involved in cases and watch people. There was a lot of debate about what was the right way to train, and this had become a major issue. And that was one of the things that Mark very successfully resolved in the programme. And he said, I don't mind how you train, as long as you train, and the unit of the currency unit for training was a case, and filling an assessment to that case called a gas form. So it didn't matter if it's in-reach, out-reach, immersion, as long as you filled in the form,
Tell us what the gas means, Tom. It's not calorie gas.
So that's the Global Assessment Score Form, which is a formative assessment form. So you take a laparoscopic colorectal procedure, you divide it into 12 key steps from theatre setup to anastomosis at the end, and then you get the trainer and the trainee to rate the completion of each step on a 6-way scale in terms of competence or independence. So did the trainer have to take over some or part of the procedure, which would give you a score of 1 or 2? Did the trainer have to provide minor or major verbal input to the execution of that procedure, which would be a score of 3 or 4? Or was it a score of 5 or 6? 5 being competent and safe, proficient being I couldn't do that better myself. And that allowed us to, in a non-critical way, evaluate the progress of trainees learning laparoscopic colorectal surgery. It allows us to deconstruct the procedures into all the key tasks and see which tasks were more difficult than others. It allowed us to compare trainers and trainees to see who's doing better than others, and of course which procedures were tougher. And no one would need to work for too long to understand that obviously doing rectal cancer was much more challenging than, say, doing a right hemicolectomy.
And the real key to these forms was, it wasn't a score of 1 to 6, being 1 was bad, 6 was good. It was a description of what took place. There was no criticism of a performance. The only one that had any objective measure was the score 6, which was saying this was proficient, as good as you could do it yourself. All the others just described what happened. Did you have to physically help the person, help them verbally, or did they manage it independently? It was really a measure of independence in the procedure rather than giving a judgment on the procedure.
So what you would hope is that over time and over cases they would improve, that you would see a different scoring system.
Yeah, and you take you back to the old learning curve, self-taught 150 cases, and what we found that by providing a good environment for training, that we saw people achieving competence in 15 to 25 cases. We validated the reliability of the system by cross-referencing it with clinical outcomes, and saw that during training that patients were not being harmed, and that your conversion rate was low, 5%, that the post-op morbidity mortality was low, hospital stay 4 to 5 days. So the process of training was not resulting in harm to patients, as we had seen in the 90s when people started to uptake colorectal and lap cholecystectomy in an uncontrolled way.
There were 1,600 cases done in the training programme, so a large volume of cases.
Now, I remember we had a lot of visiting surgeons that came in, and Tom would take them through cases, and there were no problems with whether we saw any problems with those cases. And I bet actually as well the surgeons that you trained did their open surgery better, because it was a actual training exercise. They'd never had anything like this. We've never had anything like this in our age, Bill. Well, we didn't never know how to train anything. We just sort of, get people operate with us and hope they picked up something and then help them a bit. And
this score made the trainer and the trainer.
Do one, teach one.
Well, that was.
But I think it's a very interesting concept of the learning curve, which I have written some things on the learning curve, and I had a disastrous learning curve when I started doing peritoneal malignancy, which Tom knows about, and I tried to publish. It was so bad I couldn't get anybody to publish it. But of course the problem is that there is undoubtedly in everything that we do there is a degree of learning, because otherwise nobody would ever learn anything. And I think it's how you manage that safely, isn't it? So for instance, if you have a trainee doing an operation, it's going to be slower, but you have to accept that, but you don't want it so slow that the operation goes on so long that the patient does badly. And I think that's the important role of this.
One thing we learnt is that we developed a LAPCO sort of risk prediction system, which told us with very obvious entry points of saying, is this a male rectal cancer? Is the BMI over 30? Is it a in advanced cancer, T4 cancer? Has the patient had many operations before? And we generated a 0 to 10 score where 8, 9, 10 are the very difficult cases. And of course, guess what? We found those cases had poorer clinical outcomes regardless of who did them. And we also found that if it was a training episode, in the majority of those 8, 9, 10 difficult cases, the trainer would just have to take over anyway, and it lost its value as a training case. And that taught us that you can actually sit down with a trainee and say, well, what case are we doing today? Score 1, 2, 3 on the Lapco risk prediction. This is a great training case, matches your early stage training, whereas an 8, 9, 10 case is only suitable for an experienced trainer or a trainee who's developed the skills and is ready to pass out and tackle at least some elements of these more challenging cases.
I was going to actually say one of the aspects of all that we do is selection and decision making, and that's one of the problems I think is in surgery is it does take a long time to learn technically. I heard that we had a pilot who spoke to us in Dublin, and he said you could teach people the technical skills much quicker than you could teach them on non-technical skills, the decision making, rapid decision making when something goes wrong. So he said you could train pilots quite quickly to do the technical bits, but it was the non-technical bits, and that's perhaps...
we're going to come back to that when we talk about train the trainers. Someone once told me that decisions are more important than incisions. I think that was you.
The other interesting concept, and this is really interesting, Bill, because I remember when I was a registrar and everybody said, well, it's right hemicolectomy is an easy case and rectal cancer is a difficult case. And I always felt that wasn't actually completely right. And they're not that easy laparoscopically.
I always said it wasn't completely
I know you did, but the interesting thing was what I worked out, I think, after a while, and I think, Tom, you both agree with this, the ideal case for the early phases of laparoscopic surgery is probably an early sigmoid cancer.
The sessile polyp.
Sessile polyp. So you actually, because once you go in, the anatomy is right there. The right colon is so mobile with the omentum wrapping around it and so on. It's not that easy. And I think some people made that mistake in laparoscopic surgery, Tom, didn't they? They sort of...
I think we were slightly spoiled because we'd worked for Bill. And Bill always loved a right hemi and loved a medial to lateral approach. He loved taking the vessel. And I remember very clearly once as the registrar, you said, what's on the list? And I said, there's always just a right hemi and a hernia, because you were going to the college and you didn't go to the college. You said, no, I'm going to stay in. And it was an education because I'd never seen a right hemi. I was taught you grabbed the cecum, you pulled hard, and you put a kind of clamps across, and it was a 25-minute operation. And you managed to sort of make it last about 3 hours. But actually,
I believed in starting with this
time to set out the vein.
I remember both of you taking me through right hemis in ways that I hadn't seen before, and particularly with, say, a transverse colon tumour, how to thoroughly skeletonize the greater curve to make sure you got all of that potential cancer-bearing tissue away, echoing the way that you first described TME.
Well, it's the same embryological principle, isn't it, really?
And of course,
and it made laparoscopic surgery much easier because this was not, I wasn't unfamiliar with that approach.
But I think for a patient, of course, the right colon cancer is just as important as a rectal cancer. But I think, and technically, I think that's what I've seen, Tom, even down to the years. The right colon cancer can be very difficult laparoscopically with a very mobile, flexible, colon with a big omentum. Not that easy. And of course we know now that there are benefits. Precision surgery in the right colon has got huge benefits as well.
Subject of a whole
You haven't mentioned MRI, and of course for the decision making in advance, that's become really important.
Well, and CT, I mean, if we're talking about colonic primarily here, which we kind of are, I mean, I like looking at the non-pathological anatomy of, say, the splenic flexure and the vessels before I'm doing a laparoscopic resection. I think one thing that laparoscopy pushes you to do is to really use the imaging to guide you in a way, because it's easy to pick up the splenic flexure, mobilize it open and see which bit you need, but you don't get that opportunity with laparoscopy. You've got to know before you go in which bits you need to mobilize and where they're going to be.
And I think what's really very relevant to this section about the LAPCO program is you've got updated results.
Yeah, so we started out with 144 trainee consultants between 2008 and 2014, and worked all the way through, and huge credit to Professor George Hanna's department at St Mary's Imperial College Academic Surgical Unit, and the 3 PhD fellows that came through that unit for LAPCO throughout, analysing all of the data. But we took, of the 144, 108 continued to do reasonable volume laparoscopic colorectal afterwards, and we looked at their laparoscopic colorectal data before and after the programme, 3 years either side, and compared it to an equivalent group of UK laparoscopic colorectal surgeons who had not trained in the programme. And we're talking big numbers, thousands of cases. The only weakness in the data set is it all comes from HES, which has problems in terms of how it's originally captured.
Can you tell us what HES is?
HES is the National Hospital Episode Statistics System run by the NHS, and it's essentially the source of the data is clinical coding data from hospitals. And of course we don't always have total control as surgeons as to how that data is entered and who it's entered by. But if you look at things like hospital stay as one endpoint, that tends to be quite realistic, because it's a hard endpoint that's easy to look at.
It's getting better. HES data is getting better,
definitely
much better than it was.
So in
as is mortality is another one which is quite
mortality,
defined.
death is a good endpoint to look at. So we looked at the data,
Rather important.
published in October 2020, and what we found was that no surprise, the laparoscopic LAPCO trained surgeons had increased their use of laparoscopic colorectal by 40%. They had done so 20% more so than people who had learned and were practicing laparoscopic colorectal surgery on their own. They also had a lower 30 and 90-day mortality, fewer re-interventions, and a lower readmission rate. So by any reasonable standard, the surgeons that were trained through LAPCO became better laparoscopic colorectal surgeons than their equivalent, their peers, who had taught themselves through fellowships and through other types of training as was available. So that's the sort of cherry on top of the icing of the LAPCO cake that sort of proves and tests the efficacy of an educational intervention and says this was a worthwhile program. I suppose on top of that, I'd just add that we also did a sort of a theoretical health economic calculation based on things like reduction of complications, conversion to open, which we know is costly, and of course hospital stay, which is costly, and worked out that despite the program costing the UK taxpayer around 7 million, that we net saved the UK taxpayer almost £12 million through providing a high quality training program.
I think you also did something very special, which was judge people with the judges blinded as to whether they were looking at who they were looking at.
There was a summative
so you
video
could
assessment.
be saying, this is a terrible operation. Actually, it might well be
your
the
best
professor.
Tom was a prolific assessor, so he can describe the LCAT system.
So there was a summative assessment at the end of the programme where people would submit ideally a video of a left and a right case, 2 videos, and they would be marked by 2 independent assessors, blinded. They didn't know whose video they were looking at, and if there was a discrepancy between their scores, a third person would assess the videos, and the laparoscopic competency assessment tool broke down all the steps of the procedures, and you'd score people from 1 to 4. It was a really quite a precise form, and you'd look at the different bit, mobilisation, vascular pedicle, anastomosis, and then we looked at correlating the score with both patient outcomes and looking at also their gas forms, and you could see that people who had scored 5 or 6 who had a good score in their gas forms would get a good CAT score, and the people with high CAT scores had better outcomes. And there was no legitimacy to this. This wasn't something that made you. It wasn't a pass-fail in terms of you'd be stopped.
Culture,
what would happen is Mark would write a letter saying you had had a good score, and the programme recommended that you could continue with laparoscopic surgery, or he would just write to say that you had a school which suggested you should do some more training.
Or think about your case selection,
Yeah.
but you should, whatever you do, continue to be subject to your own hospital's governance processes, continue to audit your own work, and be mindful of good case selection.
Now, we've spent a long time on this, and I think we need to move on, but there are a couple of things. One of the aspects is, could this work be done, Tom, by some artificial intelligence mechanism scoring videos? And of course, the robotic platforms are going to have inbuilt systems to monitor and measure.
The robotic platforms know what we've done.
Yeah.
So you don't have to videoate it, because they can tell exactly what you'll move. So they'll give you an immediate analysis. So you can go on these robotic platforms now and play straightforward games where you move pegs around or cut something out, and it'll score you immediately afterwards as to how many movements did you make. It can compare you to other surgeons, and it can tell straight away whether you're dexterous or not. Now, whether that doesn't deal with the non-technical things, but it does allow you to select out people. There's very interesting work going around. Somewhere like Orsi in Belgium, which is a big centre run by a urologist, Alexandre Motter, and he has something called Junior Orsi. And his idea is you get medical students in, and you get them to come and play and learn on the robots, and you'll pick people, medical students who are going to be good, who will be good surgeons.
Very interesting.
So, turning it around, he said that we need to get medical students into
it's like breeding
technology.
racehorses. You pick the winners at age 2, and then you train them for a couple of years. But we'll probably come back to that. But it's a really interesting concept, and I said this to some of the trainees in a lecture a few years ago. In your time, there will be an assessment as you're learning, but it'll also be assessing you as you're getting older. And it might tell you when you're 60 or 65, you've gone
approaching your peak.
You've gone over the top. Anyway, I think that's a really fascinating session, and I think we should move on from that. That's really fascinating. And the LAPCO program is a world famous program. It stands for laparoscopic colorectal. It's well known to be the best training program in laparoscopic surgery in the world. Well done, guys. Thank you
very much.
You can find a whole series of videos and links to our series of discussions around rectal cancer at this address. And if you have any suggestions what we might cover, please let us know. Thank you very much for joining us.